this is a revised title, which says it all, because we are talking about really bad CLL. And let's try to see what bad CLL is about. It's three different groups. The first one, you see it on the left, is patients with lesions, with aberrations, with dysfunction in this gene called the TP53 gene, and we will come to it in a minute. The second is includes patients who are refractory to prior treatment. What you see in the middle is no longer very relevant because things have changed since the publication of this proposal back in 2012. But what you see on the right is hugely relevant because it tells you that patients who progress or patients who do not respond to FCR patients who progress within 2 years have a really dismal outcome. So what can we do for these patients? How do we take decisions? There are several considerations. So not paradoxically, age and physical status is critical. Now, the median age, you've heard it many, many times. The median age of patients with CLL is 72. And you can see here on the left a typical age distribution. And what you see is that more than 40% of patients are 75 or older. And please compare to the right, because what you see on the right is the distribution, the age distribution of patients on clinical trial. So please compare 45% almost above 75 in reality, compared to only 3% in clinical trials. Is this the real world? I'm letting you to judge for yourself. And another thing, when you are old, you are bound to have diabetes, high blood pressure, kidney dysfunction, you name it. So you are bound to have what we call comorbidities. And the median number of comorbidities in any patient at that age would be 4, or even more than 4, which means that this patient will be not only compromised, but this patient will have to be taking many, many pills every day. It's been calculated that I shouldn't say patient, any individual in this age group is taking, on average, 12 different pills every day. Now, this is more or less what Chris mentioned a little while ago. It's 3 different types of patients, fit. And for fit patients, the therapy goal should be deep remission, should be great, great control of the disease. We cannot say cure, but at least we should aim for deep responses. When patients are frail, let's go to the other end of the spectrum. When patients are really frail, then the main goal is do not harm. But the bulk, the main majority of patients is in the middle. We are talking about unfit patients, where we need to be very careful about how we strike a balance between efficacy versus toxicity. The second main consideration, what was the type of first-line treatment and how this particular patient responded? Now, these are survival curves. By the way, is any of you unfamiliar with survival curves and what they mean? Because we are showing you graphs and plots and curves, but is there any one of you who is not familiar with these things and who would like a clarification? I take it as a no, so I continue. So what you can see here is that when you respond nicely to FCR, and this response lasts for more than 2 years, you are doing really much better as opposed to when your remission is really short-lived. This is the blue curve. So this goes really down. This is really bad. And another thing that we shouldn't forget is that if this particular patient has received many lines of treatment, what will happen is that with each subsequent line, the duration of response will be progressively shorter and toxicity will be increasing. So we are talking about really difficult cases. Third type of consideration, the landscape of genomic aberrations. In other words, what is the biological profile? Now, this came out more than 15 years ago, and it's a landmark in lymphoma research. Why? Because it made us realize that not all CLL are equal. So by focusing on only 4 regions of the DNA, chromosome 13q, chromosome 12, chromosome 11, and chromosome 17, the Germans could identify groups with vastly different outcome. And the worst of the worst is this red group, patients with a deletion of chromosome 17, of the short arm of chromosome 17. That's what we call in cytogenetics 17p. This is the short arm of this chromosome. And the short arm of this chromosome includes a gene, harbors a gene. It's called TP53. And the protein encoded by this gene is called p53. Now, this protein may become dysfunctional either due to a macroscopic lesion, this is a deletion, or due to a microscopic defect, this is called a mutation. Now, this protein is very critical and it regulates the cell cycle. This protein has been called the guardian of the genome, the guardian of the DNA. And it's a guardian of the DNA because it conserves genetic stability. It ensures that the DNA will not suffer from will not be defective, will not be allowed to be defective. And if its function is lost, tumor suppression is compromised. And in general, it's not only in CLL. Tumors with dysfunction of the p53 protein have a really bad outcome. Why is that? The top panel shows you what happens when the DNA is damaged. So p53 senses this damage and stops the cell from dividing. If the cell can correct the damage, fine. If not, explosives, the cell dies. Now, the bottom panel, the cell is damaged, p53 function is lost, p53 is dysfunctional, the explosives cannot come up, the cell is allowed to survive, carrying with it all the damage that it has suffered, and damage means additional defects. So this becomes a very disorganized cell. Now, this is a really horrendous graph because it shows you that at diagnosis, the frequency of aberrations of this gene is no higher than 5%. When the disease evolves and patients require treatment, it goes up to 15%. When patients relapse, it peaks at almost 50%. And if patients are unlucky to progress to what is called Richter's transformation, in other words, when CLL becomes a far more aggressive disease that we call Richter's, it's even higher, which is why testing for these aberrations is mandatory not only before first-line treatment, but before every subsequent line of treatment. And why is that? Because before, or let's say the diagnostic setting, you can have a very, very tiny fraction of the clone, a very small subclone carrying a defect. Then you give treatment, the disease relapses, and you can have a selection of these bad tumors. It's a Darwinian process. You apply a selection, and then you see the bad guys surviving. And with subsequent treatment, you are still selecting. So in the end, you are having the TP53 aberrant cells predominate. Which is why, as I told you, it's mandatory to test for these aberrations. And thorough testing means two things. FISH, fluorescence in situ hybridization, for deletion, for searching for deletion of chromosome 17p, but also screening for TP53 mutations with molecular biology techniques. And within ERIC, within the European Research Initiative on CLL, we have been very, very keen and very active in this respect. And we have established what we call the TP53 Network. We have certified more than 60 labs in Europe, but also the US and Africa and Australia for doing the analysis correctly. And we will continue to be active in this respect because we want to change what you asked, Charlotte. So, treatment options. Standard chemotherapy, you see many question marks. Chemo immunotherapy, forget about. I will say forget about, as simple as that. Why? You've heard Chris already. So these patients may respond to a certain extent, but these responses will not last long. These patients are doing really bad with FCR. And you've seen before, what chemotherapy is doing is selecting the TP53 aberrant cells. So in a way, they are harming rather than doing good. So can we do something? The answer is yes. So you remember that we emphasized yesterday that these are B lymphocytes. B lymphocytes are receiving signals from their microenvironment. So these are malignant B lymphocytes that really depend on external stimulation. In fact, one of our colleagues, Adrian Wistner, has said that these are addicted to the microenvironment. They receive various signals. This malignant CLL cell expresses various receptors and perceives signals. And these signals promote the survival and proliferation of these cells. So can we do something? The answer is thankfully yes. We can block the transmission of these signals to the nucleus. And there have been many pharmaceutical companies trying to develop drugs to inhibit this signal transmission process. And highlighted in blue on the red side of this graph, you see ibrutinib and idelalisib. These are the most effective of these inhibitors. And you see now a landmark in the history of CLL, because ibrutinib has proven extremely effective for the treatment of patients with high-risk CLL. In this study, the median number of prior lines of treatments was 5. And some patients had received even 12 different lines of treatment. And this is a really impressive result because we've seen amazing efficacy even in patients with deletion of chromosome 17p. You know what we would expect in this particular setting? Instead of having this red graph that goes like this, it should have been something like this. We've never seen something like it before. So ibrutinib turned out to be amazingly effective in this setting. But it's not only ibrutinib, because the other ibrutinib was then compared against another biological agent, which was the best that we had for high-risk CLL. This was an anti-CD20 antibody, ofatumumab, and ibrutinib turned out to be really doing much, much better compared to ofatumumab. It's shown here in yellow. And ofatumumab was doing almost nothing for patients with deletion of 17p, whereas ibrutinib was benefiting a lot. So ibrutinib is very active in high-risk CLL, is very active in patients with deletion of chromosome 17p, but ibrutinib can have serious and various adverse events. You've heard about atrial fibrillation, you've heard about bleeding risk, but these are things that are new for many of us, so we have to be extra cautious. It's not a trivial thing. It's nice that we give a pill, and these patients can have a much, much better outcome, but we have to be aware of these novel types of adverse events. A second major landmark, idelalisib. High-risk disease, idelalisib in combination with rituximab. And what you see here is identical outcome for patients with or without deletion of 17p. In other words, regardless, in this trial at least, regardless of whether the patients were p53 aberrant, they were responded nicely to the combination of idelalisib and rituximab. Safety issues again. A novel, quite distinctive profile of adverse events, diarrhea, and in some cases it can be severe, it can be delayed in onset, and it can be colitis rather than simple diarrhea. Elevated liver enzymes, this is usually reversible, but it's really of concern. And pneumonitis, thankfully it's rare, and you've seen already from Chris that there are recommendations about how to manage these complications. So amazingly effective, yes. Safety issues, again, yes. So we need to be extra cautious. Now, another type of intervention and another landmark in the management of CLL. It's this drug called Venetoclax, which targets this protein that is called BCL2. Now, it was a good idea to develop this drug. It was a good idea to intervene and try to inhibit BCL2. Why? CLL cells are long-lived, and CLL cells are resistant to this process, apoptotic cell death. A critical player, a critical mechanism for endowing the cells with resistance to apoptosis is the overexpression of this protein BCL2. So this is an immunohistochemical analysis of an involved lymph node, and we've used an antibody that can detect whether the cells express the BCL2 protein. And you see here in brown that each and every cell expresses BCL2. So it was really a cool idea to try and inhibit it, and it happened with Venetoclax after a lot of effort, because at the beginning there was another first cousin to Venetoclax called Navitoclax, but it turned out to be, really toxic. So Venetoclax proved to be effective, even, this is the second column, in patients with deletion of chromosome 17p. Finally, what about transplantation? What about allogeneic transplantation? Sorry for this horrible slide, but I will try. It's horrible because of too many numbers and words, but I will try to highlight two things. Even in the largest series, we are talking about few patients. You see here, it's less than 100. And the bottom line is that you can get a median overall survival of roughly 50 to 60% 5 years after the transplantation, but nobody is telling you with which type of life and which quality of life. So when we present and we propose allogeneic transplantation, we need to be very thorough in what we inform our patients. So it is curative. It's documented to be curative. But this was before the novel agents, before the signaling inhibitors, before BCL2 inhibitors. These drugs are effective, but their long-term efficacy is uncertain, and cure is unlikely. At least that's what we know today. The outcome of transplantation, now with the novel agents, is also uncertain. And transplantation, allogeneic transplantation, has a really high early mortality. So between 15 to 30% of patients die in the first 2 years due to complications of the procedure. And this horrible complication, chronic graft versus host disease, is something that we should never forget. So the patients may live long, but the patients have a really bad quality of life due to this thing. So, summing up, what should we be doing for patients with high-risk disease? The answer is clinical trials. This is the #1 option. You see here many things. I'm really very happy that we have options that we didn't have. And I'm really happy that within less than 3 years, we have so many molecules and so many indications. And now we have a big challenge. Which drug, which combination of drugs, to which patients, and which diagnostics? So what is the best companion diagnostics for each type of treatment? We don't have answers, and we need to work hard to find these. Future directions is clearly combinations and new agents. Relying on which things? Relying on better understanding of the biology of the disease. Thankfully, we have various targets like surface markers, like signaling cascades, like interaction with other cells, T cells, for instance, immunomodulators, CAR T cells, you name them. So it's fascinating times, but still a lot to do. That's all I had to say. I thank my collaborators, in particular my fellow ERIC board members and also the people that I'm mentioning here, and thank you for your attention.
Peter. Could you speak a little bit about future diagnostics, the price of doing genetic diagnostics seems to be coming down considerably. What might we expect in 5 years?
Okay, I will be talking about this tomorrow because I've been asked to give a third talk on future directions. And in my view, future directions means matching individual profiles with particular treatments. And you cannot do this unless you have a good, solid idea about the biology of the tumor, but also the physiology of the host. Now, you are very right that genetic diagnostics is much cheaper and will become increasingly cheaper. So it's really quite frustrating that in spite of all the recent developments and all the enthusiasm and all the increasing evidence about the usefulness and what you can gain from assessing these biomarkers, it's only P53 still, nothing else that is recommended. And even more frustrating, that in spite of the consensus that it is necessary for every patient before each and every line of treatment, more than 50% of patients still have no test. It's really alarming. We have to work hard to change it.
Sorry, but if the price comes down a lot, won't that make a difference in terms of approvals for that kind of testing, for more complete profiles?
But believe me, doing FISH for deletion 17p and Sanger sequencing for TP53 mutations should not cost more than 300 euros. Just consider the cost of ibrutinib, idelalisib, venetoclax, FCR for that matter, because if you are P53 aberrant, you should not receive FCR. FCR is not a cheap treatment. So, to me, it's really crazy that TP53, for instance, mutation screening, is not reimbursed in every European country. And we should work together to change this.
Michael? Yes, please.
Okay. Just regarding the testings in different countries, and I brought up yesterday about in Ireland, some patients are going into treatment without the tests. If they test for P53 or TP53 and they find a patient has it, but in Ireland there's no other option of the novel therapies except the clinical trials. Again, in my wife's case, there was no clinical trial in Ireland, so we had to look to the UK, so we had that difficulty. So it's when chemo is the only option for treatment.
It's a sad situation.
Yeah.
I will be very frank with you. It's something. I'm really, very motivated to be speaking now also on behalf of Eric, not as Kostas only. I'm very motivated to collaborate with you. That's why we are here, to advocate and to change this. And it's really interesting that the European Union and the European Hematology Association decided, after many years of lobbying, to come together and try to think of how we can harmonize the legislature in the different member states. It's really varying tremendously from country to country. So we have to harmonize it and ensure that patients will have the possibility that there will be no trials and that patients will not face this type of problem that you mentioned. Now, with regards to testing for TP53, one of the aims of the TP53 network established by Eric is to provide this test for those countries who have not yet implemented it. So to give you an idea, our institution, my institution, is serving as the reference lab for Greece, but also some of the neighboring countries. So what we have done, we have trained scientists, diagnosticians from Macedonia, from Serbia, now from Slovenia, and we are happy that they have now implemented the test in Belgrade, in Skopje, in Ljubljana. But until they were, confident that they were doing it well, we were happy to assist. So we were doing the test in Thessaloniki. That's what we did with Belgrade, for instance. Now, this is part of the aims of the network, and so if you know of a country or of a city where this test is not performed, you may contact Eric, and we will try to find a solution.
Thank you very much.
One very quick one, Charlotte. Thank you.
Okay, I had two, so I will just choose one.
Too quick, we'll be sorry.
Okay.
Because too quick will be good. Apologies.
So the first one, at the very beginning, you mentioned, I hope I get it right, so the disproportion between the representation of elderly patients in the trials with respect to normal life. So how does it come that regulators accept this kind of trials? That's the first question. And the second one is that...
Can you repeat your first question, the final sentence? How come?
How come that regulators accept this kind of trials?
Can you please ask this question to them? Because I'm always, I will repeat what Chris said. FCR, for many years, in every review on the treatment of CLL, you would read the following statement. FCR is the new gold standard. The median age of patients in this trial was 61, and only 8% of patients were above the age of 70. Is this the reality?
Okay, so my second question is, so you established this network about the P53 testing. So there are two different tests, FISH for the deletion. So is it more important, or is it just because there is a largest number of patients with P53 deletion? Why did you choose one against the other?
I don't choose one.
Okay.
I'm saying do both, and I'm saying do both, but in a stepwise fashion.
Yeah.
So what we do, when we receive a sample, we are always doing FISH for deletion of 17p. Mm-hmm. If it's positive, okay, you don't need to do mutational analysis. But if it's negative, and it will be negative, you saw the graph. So before first-line treatment, it's roughly 15% of patients who will be TP53 aberrant due to a deletion and or a mutation. So you may have patients who are negative on FISH for the deletion, but are still positive for the microscopic defect, for the mutation. So for the great majority of patients who will be found negative by FISH for the deletion, you are still obliged to search for the mutation. Is it more clear now?
Okay, I think Milen thinks there. I think that you really brought to the table an issue here across borders around access to a critical test that will prevent people from being poisoned with an expensive therapy that basically lets the cat out of the door and accelerates progression of an aggressive disease. And this definitely does look like there is a serious area where there's a need for collaboration between patient groups and the clinical groups, and I think this is something we should discuss about taking forward. Thank you very much, Kostas. Excellent talk and excellent questions, everybody.